Hello, I'm Dr. Robert Dreicer at the University of Virginia Cancer Center, and on behalf of my fellow co-presenters, Dr. William O. and Dr. Charles Ryan, we're going to be presenting evolving insights for integrating new treatment options and optimizing outcomes for advanced prostate cancer. The educational objectives that we're going to present today is to discuss prostate cancer disease progression and the emergence of androgen receptor signaling in primary and advanced prostate cancer, describe the mechanism of action of newly approved agents and those under investigation for the treatment of castration-resistant prostate cancer, assess strategies to integrate new and emerging therapies in cancer clinical practice for the treatment of castration-resistant disease, and evaluate patient and disease characteristics that influence treatment choices and formulate a management plan to address specific considerations. This is our first ARS question. Which of the following statements about new agents in the management of prostate cancer is false? Number one, enzalutamide is best offered to men with metastatic castrate-resistant prostate cancer that are minimally symptomatic. There's no need to wait 6 to 8 weeks post-stopping steroids before considering Sipuleucel-T. Cabazitaxel is a good option for men with symptomatic metastatic castration-resistant prostate cancer. Radium-223 is approved for men with metastatic castration-resistant prostate cancer pre- or post-docetaxel with primary bone disease and some degree of pain. Abiraterone is a potent CYP17 lyase inhibitor. The next slide basically demonstrates the natural history of prostate cancer from a view of 2015. And what we see basically is a progression of disease from asymptomatic to symptomatic, from patients who have biochemical failure or non-metastatic disease to metastatic disease, and castration-sensitive to resistant disease. And what we see over the course of advanced disease in the recent years is the rapid development of a number of new drugs that are now FDA approved. The following slide shows the overall survival benefit from recent trials done in what we used to refer to as the pre-docetaxel or chemotherapy-naïve metastatic state. These are studies that were conducted and presented within the 5-year period of 2010 and 2015. We see CYP-T, docetaxel, abiraterone, and prednisone, and enzalutamide, and what you see are the comparators, the median overall survivals, and the hazard ratios. These are obviously pretty impressive results in a very rapid period of time. The next slide shows a similar survival benefit curve for patients treated in the post-docetaxel setting: cabazitaxel, abiraterone, enzalutamide, and radium-223. And again, concentrating on the hazard ratios, we're seeing 34, 37, 39% reduction in death. This is a very amazing development over a relatively short period of time. So the next slide demonstrates that one of the issues that follows, given the rapid integration of novel therapies, is that there is really limited level 1 evidence to guide us to determine what's the optimal time to initiate therapies in this population, the appropriate sequence of the drugs, or the role ultimately of combinational therapies. The next 4 slides basically are 2015 NCCN guidelines for castration-resistant disease. The first slide shows current recommendations for patients with biochemical disease only. The next 3 slides show movement from metastatic prostate cancer through castration-resistant disease. And while we're not going to spend a lot of time looking at the details of the recommendations, I think in total what you're seeing is a very rapid increase in the complexity of the management of a disease that, frankly, up until about 10 or 15 years ago, was unfortunately very simple to manage because there was limited options for management. As we move forward and look at the state of advanced prostate cancer therapeutics, early experience with next-generation AR receptor targeting agents, which we're going to cover in more detail later in this program, drugs like abiraterone and enzalutamide, one of the things that has become obvious to all clinicians is that there is a significant degree of activity of these agents, but we have now demonstrated, unfortunately, that there's a significant degree of cross-resistance between these two agents. We recognize that the new agents that have been approved are somewhat unique in prostate cancer compared to some other diseases in that we have androgen receptor targeting drugs like abiraterone and enzalutamide, but additionally, we have non-AR targets, Sipuleucel-T, immunomodulatory therapy, and radium-223, an alpha particle, which causes its damage by double-strand DNA breaks. one of the things that was sort of an initial consideration as these new drugs came online was that docetaxel, a therapy that was approved in advanced prostate cancer now more than a decade ago, would be pushed further and further down the disease course. However, recent evidence from the U.S. intergroup trial, we refer to it as the CHARTED study or ECOG-3805, has probably changed how we think about the role of docetaxel. So, reviewing the CHARTED trial, this was a large U.S. intergroup trial randomizing about 800 patients with newly appreciated metastatic prostate cancer to receive standard of care androgen deprivation therapy or the same therapy plus 6 cycles of docetaxel given every 3 weeks, standard dosing, but without the routine use of steroids. The primary endpoint of this trial was overall survival. The next slide demonstrates that when this data was presented at ASCO 2014 in the plenary session, the median follow-up was 2 years. The median overall survival in the group receiving standard of care hormonal therapy was 44 months. However, the group that received docetaxel demonstrated a dramatic improvement in survival of almost 58 months. And you see the hazard ratio of 0.61 with an incredibly strong p-value. Of note, in this study, patients either had high or low volume disease. High volume disease typically would be defined as patients either with visceral metastases or at least 4 bone metastases, 1 outside the axial skeleton. In that subgroup of patients, there was a 17-month median improvement in survival. So this is obviously critical data. We anticipate that this study will be published in the New England Journal of Medicine during this year. So as we move on, thinking about picking the right agent for the right patient, at a high level, there are a number of considerations. One, from a clinical perspective, what's the physiologic status of the patient? What are the patient's comorbidities? Does the patient have disease-related symptoms? Progressive bone pain, progressive fatigue, weight loss, and anorexia. Sites of metastatic disease. This is a patient with nodal disease only, or is there extensive bone metastases or other visceral sites? And other characteristics of the disease. Poor PSA expressing tumor, high-grade disease with a very short interval response to primary ADT. All of these clinical parameters will help us think about, in the absence of other data, what might be an appropriate initial therapy. And now I'm going to turn over to my colleague, Dr. Ryan, the next portion of the program.
Well, thank you, Dr. Dreicer. I'm going to begin with case 1. This is a 64-year-old gentleman who is 4 years out from radical prostatectomy. At the time, it was a T1C tumor with a Gleason 3+4 = 7 pattern. His initial PSA was 7.3. 2.5 years ago, he completed salvage radiation therapy because his PSA had risen to 0.56 after surgery. Now his PSA is 13.5. Using the last 4 values, his PSA doubling time is 7 months. He's asymptomatic and enjoys a good performance status, ECOG 0. A bone scan is performed and is negative. A CT scan of the abdomen and pelvis is shown in the next slide. As we can see, this is retroperitoneal adenopathy, measuring 1.3 centimeters in one node and 2.8 in the other along the left para-aortic region. So this is a patient with low volume, asymptomatic, metastatic disease. And there are a number of questions that come up with regards to treatment in this setting, such as the timing of therapy, and even in some cases, the need for therapy and what types of therapy to integrate. So for the most part, patients in this setting will be offered androgen deprivation therapy with a combination of an LHRH agonist or antagonist, and typically an oral anti-androgen such as bicalutamide. With respect to the nature of the therapy, it remains a bit controversial as to whether or not intermittent hormonal therapy is appropriate for such patients. The vast majority of patients are typically not offered intermittent hormonal therapy, and there are a variety of studies that have looked at this issue. With regards to the utility of the new next-generation AR-targeted agents, it's really too early to integrate Enzalutamide or Abiraterone or any other such new agents into this treatment time. and as those agents remain typically utilized in castration-resistant disease. As we think about the nature of the metastasis, we'll go to the next the question slide, which states, in patients with CRPC and visceral metastases, patients with CRPC and visceral metastases were not included in which of the following phase 3 trials and therefore should not receive therapy with the corresponding agent. So just to clarify here, we're not talking about androgen deprivation therapy as initial therapy. We're now talking about a CRPC setting. Was it in the ALSYMPCA study with radium-223, the PREVAIL study that led to the approval in the pre-chemotherapy setting of Enzalutamide, the IMPACT study, which included Sipuleucel-T, the TROPIC study, which included cabazitaxel, or the COU-302 or COU-302 study, in which Abiraterone plus prednisone was compared to prednisone plus placebo? Well, the answer to the question is that the ALSYMPCA study is probably the most appropriate answer here, because that is an agent that is specifically developed for bone metastasis and specifically developed for symptomatic bone metastasis. One of the other trials, the COU-302, also excluded patients with visceral metastasis. However, the use of abiraterone has been validated in the setting of visceral metastasis in the post-chemotherapy setting. It's important to note that the PREVAIL study, the IMPACT study, and the TROPIC study all, interestingly enough, did allow the inclusion of patients with visceral metastases, and this was typically a minority of the patients. We'll talk about each of these studies. Sipuleucel-T is an active cellular immunotherapy. It's been approved now for a few years, and it involves a procedure in which the patient's white blood cells are harvested. They undergo a short-term culture with a protein cassette that essentially acts as an antigen. The antigen in this case is prostatic acid phosphatase, and it's coupled to GM-CSF to enable uptake of the antigen by the immune cells. This incubation takes place for about 40 hours. The cells are then shipped back to the facility where they are reinfused to the patient. This occurs on 3 different occasions, 14 days apart. So it's really not a continuous therapy. It is a 3-treatment program. The approval of Sipuleucel-T came on the heels of the IMPACT trial, Immunotherapy Prostate AdenoCarcinoma Treatment, that's the acronym, trial. And it's important to know who were the patients treated and what were the results. First off, these were patients who had asymptomatic or minimally symptomatic mCRPC. They were randomized in a 2-to-1 fashion to receive Sipuleucel-T or placebo. At the time of disease progression, patients were treated at physician's discretion. However, patients who initially received placebo were offered the opportunity to be treated with Sipuleucel-T. And a large proportion of placebo patients did, in fact, receive Sipuleucel at the time of crossover. This study was published in 2010, and the patients were enrolled in the study in the time period of around 2006 to 2008. I think it's important to keep that in mind because this was before the availability of the current era of agents such as Abiraterone and Enzalutamide. The baseline characteristics, I've stated the key inclusion criteria are above. This was a patient group with a median age of 71. The median PSA was about 50, hemoglobin 12.8. 50% had bone-only disease, and a small proportion, and a significant other proportion had bone and soft tissue disease. And as I mentioned earlier, a very small proportion actually did have visceral metastases. These selected patient characteristics do compare relatively favorably, as we will see, to both the PREVAIL and the 302 studies. This is the Kaplan-Meier curve for the survival benefit associated with the Sipuleucel-T treatment on the IMPACT study. And as you can see, the median survival difference is 4.1 months. However, that's associated with a hazard ratio of 0.775. So in other words, the risk of death in the treatment arm that received Sipuleucel-T was reduced by about 23%. And that's the way that I think about this. And the study was adequately powered to demonstrate this and was associated with a p-value of 0.032. So this is a randomized, prospective, placebo-controlled trial that demonstrates a survival benefit to the use of this agent in patients with what essentially amounted to lower volume metastatic CRPC. And that's why we bring this up a little bit earlier in the talk today, because it is to be contrasted with some of the other agents that are available in this area. I like to make the point that when one looks at the IMPACT trial and when one looks at the impact of Sipuleucel-T compared to placebo in the patients with the lower volume disease, and in this case on this slide, we are slide 9, we're demonstrating that patients with the lowest quartile of PSA, they actually had a hazard ratio that was 0.51, so almost a 50% reduction in the risk of death upon receiving Sipuleucel-T compared to placebo. And that, I think, is a quite impactful hazard ratio, and this is the area of the disease in which I seek to integrate Sipuleucel-T if I am going to use it. And I should say that in my practice, most of the patients who are receiving Sipuleucel-T are in this disease range. They do typically have early castration-resistant prostate cancer. They do not have a high burden of disease. They are not symptomatic, as that would go against the label. And I think that these data support that early use if it's going to be used. Slide number 10 now introduces Abiraterone. Abiraterone acetate is an oral agent that has now been approved for a few years. It inhibits the CYP17 enzyme complex. It's actually a derivative of progesterone, and it, in a sense, mimics precursor androgens in the androgen synthesis pathways. The difference between Abiraterone and other androgen deprivation therapies, such as orchiectomy or GnRH analogs, is that Abiraterone targets androgen production both in the adrenal glands as well as in the testis if they remain active, as well as intratumoral androgens, which we now know to be an important component of disease progression. So it's a more comprehensive way to inhibit androgen production. In this slide in 11, we see that there is a somewhat complicated feedback mechanism that happens when a patient takes Abiraterone. Essentially what happens is Abiraterone will inhibit androgen production, and part of the feedback to the hypothalamus will be increased ACTH production. And this is in part due to a transient decrease in cortisol. Abiraterone doesn't really cause true adrenal insufficiency, but it does cause enough of a decline in cortisol to stimulate ACTH production. What ACTH production will then do is stimulate cholesterol conversion to pregnenolone, and thus will potentiate the development of mineralocorticoid precursors, not so much aldosterone, but its precursors. And the mineralocorticoid precursors can lead to hypokalemia, hypertension, and fluid retention. Now, all of these potential toxicities can be significantly reduced in terms of their risk and incidence by co-administering Abiraterone with a low dose of prednisone. So the current label for Abiraterone is that prednisone should be given at 5 milligrams twice daily, and that's the dose that I use in patients in my practice. In patients who are co-administered with the prednisone, they still need to be monitored for hypokalemia and hypertension, of course, but the risks of those phenomena are significantly decreased. Most importantly, in slide 12, we see that we get a durable and very sustained and profound reduction in androgens. And so the A, B, and C panels along the top demonstrate what happens to the androgens when Abiraterone is administered. For the most part, androgen production or androgens in the serum are reduced to zero. Along the bottom, D, E, and F, we see the corticosterone and deoxycorticosterone levels and how they increase with Abiraterone treatment. Now, this is Abiraterone monotherapy treatment shown in this slide and published in the paper in the Journal of Clinical Oncology in 2008. So corticosterone and deoxycorticosterone are aldosterone-like molecules, and that explains the toxicity. And this slide essentially shows, again, the issues that arise when the corticosteroids are co-administered. The aldosterone and corticosterone levels are then decreased, thus improving the safety of Abiraterone. Slide 14 is the introduction to COU-301. Now, this was the trial that led to the approval of Abiraterone and still forms the basis for much of its use worldwide, although relatively less of its use in the U.S. COU-301 was a study for patients who had already received docetaxel. At the time that this study was initiated, around 2008 or 2009, docetaxel was the only systemic agent that had been proven to have a survival benefit. And therefore, once a patient had progressed on docetaxel, there were few realistic treatment options available for them. The treatment was Abiraterone plus prednisone versus placebo plus prednisone, and the study enrolled a little over 1,000 men in a 2-to-1 randomized fashion, with a primary endpoint of improving overall survival by 25%. These patients were allowed to be symptomatic. They were allowed to have visceral disease. They were stratified by performance status, pain levels, prior chemotherapy, and the types of progression they had experienced. In other words, had their PSA simply risen or were they experiencing new tumor growth? Slide 15 shows the Kaplan-Meier curve that demonstrated a substantial improvement in overall survival with Abiraterone compared to placebo. The hazard ratio for this study is 0.65, so that's a 35% improvement in survival, or I should say a 35% reduction in the risk of death for those patients who received Abiraterone. The difference in the median survivals was 14.8 versus 10.9, so 3.9-month difference in the median survival. However, that number doesn't really demonstrate the magnitude of the benefit for those patients who experienced a response to the drug, and we'll get to that in later slides. Consistent with the mechanism of action of Abiraterone, fluid retention, hypokalemia, and cardiac disorders were seen in patients receiving this drug. Hypertension occurred in about 10% of patients, which interestingly is not that much higher than patients who received the prednisone. But these are the toxicities that physicians need to monitor patients for, even in the pre-chemotherapy setting, as we will see briefly. Moving on to question number 2, is in the COU-302 study, which we have not yet reviewed. In that study that defined the use of Abiraterone in the chemotherapy-naive, minimally symptomatic patient, which of the following best describes the definition of radiographic progression? Is it number 1, any new lesion on bone scan? Is it 2, RECIST-defined progression on CT scan? Is it number 3, a PSA rise and a new lesion on bone scan? 4, clinical progression to pain or 2 or more new lesions on bone scan? Or was it a PSA rise alone? The most appropriate answer to this question is going to be number 4, clinical progression to pain or 2 or more new lesions on scans. And I think the importance of that issue will become obvious as we go through the 302 study design. So 302 was a study that was designed to explore the efficacy of Abiraterone in the chemotherapy-naive patient. I think of this as a very important study from the perspective of the fact that only about 45% of patients with CRPC were ever receiving docetaxel chemotherapy. So it was very important for us to develop not only Abiraterone but other therapies in the chemotherapy-naive patient population because it allowed more patients to receive life-prolonging therapy. So the study was a multi-center study that had a 1-to-1 randomization between Abiraterone plus prednisone or placebo plus prednisone. And again, patients were asymptomatic or mildly symptomatic. And by mildly symptomatic, what that meant is they could have some pain, but if they took opiate analgesics within 28 days of enrollment, they were considered ineligible. Slide 19 shows the radiographic progression-free survival data. And I should say that this study had 2 primary endpoints. Primary endpoint number 1 is what we're seeing here, radiographic progression-free survival. Primary endpoint number 2 is overall survival. And so radiographic progression-free survival in this study was specifically designed as a primary endpoint, and therefore it incorporated a number of important clinically relevant variables. So, for example, a patient who started out asymptomatic as required by the study eligibility who then went on to develop symptomatic disease and required opiates, that was considered a radiographic progression-free survival event. So don't be fooled by the fact that it's called radiographic progression-free survival. It didn't require radiographic progression. It required radiographic progression and or progression of some other type, such as to pain, decline in performance status, need for chemotherapy. The reason why I think that this is important is that as we counsel patients today about the appropriate and timely use of this agent, and we help manage their expectations, it's important to know that when we state that the median radiographic progression-free survival on Abiraterone was 16.5 months, we know that we're not discontinuing the therapy simply because of a PSA rise. And in point of fact, many patients experienced a PSA rise for many months prior to experiencing radiographic progression. And I think that that's a key management point for how we use not only Abiraterone, but the same will apply to enzalutamide. Over time, the overall survival of the 302 study evolved. At the second interim analysis of the study, the treatment was unblinded upon unanimous recommendation by the Independent Data Monitoring Committee. At that time, there was not a statistically significant improvement in survival observed, but over time, as the data matured, and as we now know, there is a statistically significant improvement in overall survival, as is shown here. In the Abiraterone arm, it's 34.7 months. In the prednisone alone arm, it's 30.3 months. And the hazard ratio there is 0.81, so it's a 19% improvement in survival. Now, one of the complicating factors in this trial was the fact that the majority of patients received not only one, but two subsequent therapies, and in fact, 44% of the patients on the placebo arm did eventually receive Abiraterone. And so those types of factors always will create an effect on the overall survival curve, and this was certainly the case here. So it's very interesting to see that with the prolonged follow-up, the survival benefit did emerge. On to enzalutamide. Enzalutamide is a slightly different drug from Abiraterone. Abiraterone, of course, blocks androgen production, as we talked about. Enzalutamide has a number of effects. Number one, it inhibits the binding of testosterone and its derivative, dihydrotestosterone, to the androgen receptor. Number two, in doing so, inhibits the activational change by that binding. So the androgen receptor doesn't change its shape, and as a consequence, isn't able to translocate into the nucleus and bind to DNA. And the androgen receptor must translocate into the nucleus and bind DNA for it to exert all of the stimulatory effects on the cancer. The study that led to the approval of enzalutamide is called the AFFIRM study. This is very similar to the 301 study with the Abiraterone, essentially the same patient population, essentially the same sample size. One difference, however, is that enzalutamide was compared to a true placebo, whereas the Abiraterone arms, the control arm was placebo plus prednisone, and it turns out that prednisone is active and about 25% of patients will respond to it. However, in the AFFIRM study, the primary endpoint was overall survival, and there was a very nice separation of the curves that occurred very early in this study, as we see here on slide 23. And the median survival for enzalutamide in this study was 18.4 months compared to 13.6 in the placebo arm. That is associated with a hazard ratio of 0.63, which is a 37% reduction in the risk of death when patients took enzalutamide in the post-chemotherapy setting. Enzalutamide has a slightly different side effect profile from Abiraterone. One of the major issues in its early development was the observation of seizures in a number of patients who took the drug at high doses. In the phase 3 study, seizures were quite uncommon, occurring in 0.6% of patients and typically occurring in the setting of some mitigating factors such as a procedure or other medications. Of all of the side effects of enzalutamide, the one that stands out the most and I think is the most clinically relevant is fatigue. It can be an agent that can induce a fair amount of fatigue in patients, and as you can see in this slide, 34%, or about a third of patients, complained of fatigue with this agent, and 6% had greater than or equal to grade 3 fatigue, which would be quite debilitating fatigue. The PREVAIL study shown in the next slide is an analog to the COU-302 study. It's pre-chemotherapy, or I should say chemotherapy-naive patients. Again, testing this asymptomatic and mildly symptomatic group now that we've seen here in PREVAIL, previously in 302, and previously in the IMPACT study with Sipuleucel-T. And it also employed co-primary endpoints of radiographic progression-free survival as well as overall survival. Now, keep in mind that the patients who were enrolled into this study were not allowed to have received prior Abiraterone. Here's the progression-free survival curve, which has been published now by Dr. Baer in the New England Journal of Medicine, showing that the enzalutamide led to a massive improvement in radiographic progression-free survival, and the hazard ratio here was 0.186, so an 80% reduction in the risk of progression. Keep in mind when comparing this to the Abiraterone experience, that in the Abiraterone experience, the control arm was prednisone, and as I mentioned, about 25 or so percent of the patients had a 50% decline in their PSA on the prednisone. So that is one comparing factor. Here's the survival curve from PREVAIL. Note that this survival curve separated immediately, almost, and was associated with a hazard ratio of 0.71, or a 30% roughly reduction in the risk of death. And this was observed at the interim analyses, and of course formed the basis for approval of of enzalutamide in the pre-chemotherapy setting. With respect to PREVAIL and AFFIRM adverse events, I've mentioned them mostly. Seizures occur in less than 1% of patients, and actually in 0.1% of the chemotherapy-naive patients, who are generally a more well patient group. The most common adverse events are fatigue-related, asthenia, fatigue, and the other ones are noted here, such as decreased appetites, arthralgias, etc., as you can see. So the FDA recently updated the treatment indications for enzalutamide about 8 months ago in September of 2014. And the label now reads that patients treated with enzalutamide patients may be treated with enzalutamide and continuing GnRH analog. And by the way, that's something I haven't mentioned, but that is a standard feature of all of these clinical trials, is that patients continued on with their GnRH analog, their medical castration. So now the label covers both the chemotherapy-naive group and the patients who have received prior docetaxel chemotherapy. Looking forward, we are now in the middle of a large phase 3 trial that is combining these two agents. This is being run by the Alliance for Clinical Trials in Oncology, a U.S. cooperative group. The trial is still enrolling and has the sole primary endpoint of overall survival. So because these agents have similar but not overlapping mechanisms of action, it is hoped that there may be some additive or synergistic benefit to the combination of these two agents. There are a number of lessons to be learned and things for us to still consider in a thoughtful manner as we treat patients with these next-generation AR-targeted agents. Number one is the optimal timing to initiate therapy is not yet defined. I mentioned asymptomatic. I mentioned minimally symptomatic. I didn't mention it, but the median PSAs in both of these trials is around 50, so around the same PSA range as the Sipuleucel-T studies. So it's just not known whether there's an advantage to initiating therapy with an asymptomatic patient with a PSA of 5 and a low burden of disease, or a PSA of 45 and a slightly higher burden of disease. Our early indications from the sub-analyses of these studies is that the patients with lower burdens of disease have a better prognosis, but the true hazard ratio and the true advantage of the therapy is still being evaluated. Another important point, and I alluded to this earlier, is when is the appropriate time to discontinue treatment with abiraterone or enzalutamide? And in both of the studies, clinical and radiographic progression were the primary endpoint of the study, and importantly, PSA or biochemical progression was not necessarily a reason to discontinue therapy on the studies. Now, in my own practice, I will tell you that I do the following. If I treat a patient with abiraterone or enzalutamide and they experience no decline in PSA whatsoever, immediate resistance, I typically will discontinue that therapy after a maximum of about 12 weeks. The likelihood of a response occurring after that time is rare, and we now know that there are molecular features that lead to primary resistance to these agents, and it's probably best to move on to the next type of treatment for those patients. However, in a patient who experiences a 50% or a greater decline in PSA, and that is the majority of patients, I don't discontinue the therapy when their PSA begins to rise. I will watch for a pattern of PSA rising, and in many cases, the PSA may rise for 5, 6, or even 10 or more months before radiographic progression occurs. And in reviewing the data from both of these trials, it is my belief, and I think a current discussion in the field, that there is continued benefit from continuing these treatments, even in the face of a slow PSA rise. And in the next slide here, 32, we make that point that there was a sign of some continued benefit, even in the face of a rising PSA. And so I would encourage clinicians to not discontinue these drugs too early. There is also ongoing discussions about lessons learned about cross-resistance. So retrospective studies demonstrate that the second of these two drugs that is used when they are used in sequence is not as good as the first. And that may be because we have selected out a more resistant tumor biology. And so while it is reasonable to take a patient who is on enzalutamide and try them on abiraterone or vice versa, it should be done cautiously and with tempered expectations for success. And so this is something that we don't have prospective data on, but it is being studied. Early on there was some suggestion that prior abiraterone or prior enzalutamide may have some adverse impact on docetaxel response rates, and I think over time we've come to appreciate that that's probably not the case. Docetaxel and its cousin cabazitaxel continue to have activity even in prior patients who were previously exposed to abiraterone, and I wouldn't use that in my treatment decision making. There is a lot of work being done on potential mechanisms of cross-resistance to next-generation AR-targeted agents. There was a paper that generated some interest a couple of years ago that looked at glucocorticoid activation of the androgen receptor. I would have to say that that has not been validated, and I would not say that that paper should tell us that we should not treat patients with corticosteroids. In my own practice, and many of my colleagues agree, glucocorticoids may still offer palliative benefit and lead to responses even in the abiraterone or enzalutamide refractory setting. There are a number of other studies underway which look at mutations in the androgen receptor, splice variations in the androgen receptor, and mutations in dihydrotestosterone function. Furthermore, I think over time we are getting more data that tells us about the possibility of subtypes of prostate cancer emerging. And I predict that in the coming years, we will learn a lot more about things that we currently don't have a firm grasp on, such as the neuroendocrine phenotype, the anaplastic phenotype, the small cell phenotype of prostate cancer. A lot of people use those terms interchangeably, and I think that will become clearer as some of the work that's being done gets published. The bottom line is with this neuroendocrine and anaplastic phenotype is we tend to believe now that this picture is one of rapidly progressing disease, often involving visceral sites and refractory status to enzalutamide and abiraterone, and sometimes with a low or even zero PSA. Over time, we are becoming more aggressive in doing biopsies and trying to characterize this. This remains largely a research center tool doing biopsies in metastatic disease. However, when a biopsy reveals a conversion to a small cell phenotype, that will drastically change the treatment options. And so it is an option for clinicians out there to do a biopsy to see if a small cell phenotype has emerged. And of course, if that is evident, then platinum-based chemotherapy would be considered a reasonable option. So with that, I will conclude my part of the talk, and we'll turn it over to Dr. William O.
Hello, my name is William O. I'm the Chief of the Division of Hematology and Medical Oncology at Mount Sinai Medical Center, and it's my pleasure to continue this discussion of prostate cancer and the new treatments for castration-resistant prostate cancer. So as you see in this next case, this is a 66-year-old healthy gentleman who presented initially with progressive lower urinary tract symptoms, had a PSA 5.7, but actually presented with a very high-grade prostate cancer, and at the time of his diagnosis had multiple lesions on his bone scan. We don't actually see patients like this as much anymore, but we still do have some of these patients who present with the primary metastatic disease. He was started on complete androgen blockade with both an LHRH agonist and a first-line anti-androgen, and his PSA did decline and nadir'd at 0.17. Now, one of the interesting things about this nadir of 0.17 is that although it's a significant drop, we do know that unless your PSA nadirs to 0, your outcomes may be worse. This comes from a SWOG trial where the outcomes in metastatic disease were directly related to the depth of a PSA nadir while on androgen deprivation therapy. So if patients, for example, did not nadir below a level of 4, their survival was measured in about a year. Whereas if they nadired below 0.2, and this patient did nadir below 0.2, their outcome was more like 4 to 5 years in terms of overall survival. But in general, we like to see the nadirs go down to 0. Unfortunately, he didn't nadir at that level, and his PSA actually started to rise to 0.15, and he had a bicalutamide withdrawal. Bicalutamide withdrawal has been around for many years. Certainly if a patient starts on complete androgen blockade, it's reasonable to stop the bicalutamide, and rarely we will see a decline in PSA just on the basis of bicalutamide withdrawal. Now in this situation, the patient did not have a significant withdrawal response. It's 13 months from the time of his initial ADT, which is not a very long time. It's shorter than what I described earlier, but not surprising given that he had presented with a very high Gleason score tumor. He's now having symptoms with low back pain and hip discomfort bilaterally, and his PSA has risen quite quickly and is 16.1. He had a CT scan of his abdomen and pelvis, which showed no lymphadenopathy. So in some ways, this is a typical metastatic patient in that he has bone metastasis. Unlike earlier situations, this patient is actually symptomatic, and he has no soft tissue disease that we're aware of. And as you can see on his bone scan image, he has multiple bone metastases along his spine as well as his pelvis, and he's having pain in both of those locations. So symptomatic patient with metastatic castration-resistant prostate cancer with a relatively short period of androgen deprivation response and a nadir PSA that was predictive of progression. So if you look at the next slide, again, you see that what is really happening is what are the questions that are going to be relevant for this patient? First of all, does he need therapy at this point, and when should you start the therapy with regard to the PSA and his symptoms? What is the role and utility of next-generation androgen receptor-targeted agents versus chemotherapy and radium-223? Now, one of the advantages of our current era is that we have multiple new approved therapies in prostate cancer, but one of the disadvantages, since many of the treatments were approved at the same time, is that we do not know exactly how to sequence these treatments and which treatment we should use first. To briefly review, chemotherapy was really approved initially in 2004 on the basis of the TAX-327 trial. This is a slide that showed updated data from that original registration study. And as you recall, docetaxel was compared to mitoxantrone using either an every 3-week or weekly schedule. And the weekly schedule was not significantly different than the control arm of mitoxantrone, but every 3-week docetaxel was associated with a significant improvement in overall survival compared to mitoxantrone. It was 0.79, the hazard ratio, with a p-value that was significant. So the most important thing about docetaxel in the setting of CRPC is that, in fact, it was the first treatment in the modern era that improved overall survival in CRPC and continues to be an important and active treatment. The other thing is that it became, as many of the audience knows, the registrational, what I call line in the sand, where all of the new treatments were really tested either pre or post docetaxel because this was the first approved treatment that improved survival. So the TROPIC study was the second chemotherapy that improved survival in CRPC that was approved several years ago based on this trial. The cabazitaxel was given to patients along with prednisone for 10 cycles versus mitoxantrone prednisone in the control arm. These were all patients who had already received docetaxel-based therapy and had progressed, over 755 patients, and they were stratified by whether they had measurable disease or non-measurable disease and by performance status. And the primary endpoint was overall survival. And you can see on this next slide that basically there was a significant benefit in terms of overall survival with second-line chemotherapy with cabazitaxel. The survival was 15.1 months in the cabazitaxel arm versus 12.7 months in the mitoxantrone arm. Again, prednisone was given in both arms for balance. Hazard ratio is 0.72, statistically highly significant. So just to review a question here, all of the following are true except number 1, cabazitaxel is approved second line after docetaxel. Number 2, cabazitaxel is given IV every 3 weeks. Number 3, TROPIC showed an overall survival benefit compared to placebo. Number 4, prednisone is used with cabazitaxel. Number 5, chemotherapy is associated with myelotoxicity. So generally speaking, all of these are true except for number 3, because remember the comparison arm was not placebo but mitoxantrone. So the correct answer to this is that all of the following are true except number 3. I'm going to shift now to radium-223, which was also a novel therapy that was approved in prostate cancer with bone metastasis. Radium is an interesting drug, of course discovered initially by Marie Curie many years ago. Radium-223 is an analog that acts as a calcium mimetic, and if you look at a periodic table, you can see that along that column, calcium, strontium, barium, and radium are all along the same column. And so radium naturally goes to the same areas that calcium would normally go to, and of course bone is the most important organ where calcium may deposit. Radium is excreted by the small intestine, and that's important because you sometimes do get some diarrhea with this. Now, radium is the first alpha particle approved in the treatment of cancer, and you can see some of the key issues around alpha versus beta particles. Now, beta particles were used for many years in strontium and samarium, which are radiopharmaceuticals that have some modest palliative benefit. And if you think about those drugs and now radium, you look at the key differences between alpha and beta particles, you see that the mechanism of action of alpha particles may explain why radium-223 is associated with the survival benefit. The first issue is that this is a much bigger particle. You can see it's 7,300 times the size of a beta particle. That's like throwing a bowling ball through a window versus throwing a small pea at a window. You can see it's going to be much bigger and much more mass effect. There's also much higher energy, as you can see in the second line, compared to a beta particle. So you need fewer particles to have the same energy effect. The opposite is true in terms of the range. So even though it's a very big particle, it does not have a wide range in terms of the micrometers. That's very important because if these particles deposit in bone, you do not want to have a wide range of energy because the bone marrow happens to be sitting right next to the bone. And the broader the activity, the more bone marrow toxicity you will have. And then if you look at the bottom line, the number of DNA hits to kill a cell, you can see, again, because of the large mass and energy, you don't need very many hits to kill a cell as opposed to a beta particle. So this is shown in the cartoon on the next slide, which basically shows that if the cancer is in the bone and the alpha particle radium-223 deposits in the bone, that it can potentially kill those cancer cells that are deposited in the bone but relatively spare the bone marrow. Again, this is all theoretical, but we know, from, as I'll show you in a second, that from the clinical trials that, in fact, the bone marrow toxicity is more limited with drugs such as radium-223 compared to traditional beta particles. Now, if you look at the ALSYMPCA phase 3 study design, I'll point out a few important things about this slide. The first is that patients had to have symptomatic metastatic castration-resistant prostate cancer. This is very important because, first of all, this drug, as I showed you, does not work unless you have cancer in your bones. It's a bone-targeted therapy. So if you do not have bone metastasis, you should not get radium-223. The other issue is, obviously, in order to be eligible for this study, you had to have symptoms. So the concept of symptoms is not always a well-defined one, but if you have any pain, if you have pain requiring any amount of medication, even a drug like acetaminophen, I think it's reasonable to consider a treatment such as this. The other important exclusion was that you could not have had known visceral metastases. Visceral metastases means liver metastases, lung metastases, brain metastases. This drug will not really treat those areas because, again, it goes straight to bone. Now, you could have had lymph node metastases to be on this trial, although it couldn't be bulky. So if a patient does have moderate lymph node metastases but a significant amount of bone disease, they should still be considered for a treatment such as radium-223. And then finally, the question of whether they're post-docetaxel or, quote, unfit for docetaxel. We all know that there are some patients who will refuse chemotherapy, whether we believe they should have it or not. There are some patients who might not be fit for chemotherapy. This is certainly a reasonable option for such patients. They were stratified and randomized to either radium plus the best standard of care or placebo plus best standard of care, and over 900 patients were randomized. It's 6 injections at a 4-week interval, again, important to recognize. The best standard of care concept is important, too, because patients could have received other, for example, hormonal therapies like ketoconazole or bicalutamide. In the modern era, in theory, although it hasn't been tested yet formally, they could receive androgen-targeted therapies concurrently. What they cannot generally receive is cytotoxic chemotherapy because that would be really unable to be tolerated concurrently. So you see the overall survival Kaplan-Meier curves on the next slide, and the hazard ratio is 0.70 with a very significant p-value, 14.9 months median survival versus 11.3 months. Again, remember, these are patients who are symptomatic, metastatic. Many of them had already received chemotherapy, so they have a shorter survival, but clearly better with radium compared to not. And as you might expect with a bone-targeted treatment, in the ALSYMCA trial, they looked at time to first symptomatic skeletal event, and you can see that, in fact, there was a significant prolongation in symptomatic skeletal events. This is a new term compared to what we used to call SRE, or skeletal-related events, but you can see that, again, no matter how you define the skeletal event, either symptomatic or non-symptomatic, that there was a very significant improvement in skeletal events from 9.8 to 15.6 months with a hazard ratio of 0.66. If you look at toxicity on the next slide, you can see that you do have some neutropenia and thrombocytopenia, but you can see it's mostly low grade. In the radium arm, about 5% had neutropenia and 12% had thrombocytopenia. And in terms of the grade 3-4 toxicity, it was significantly lower. And also I'll point out that there is about a total of a 25% chance of having diarrhea, although a significant number of patients in the placebo arm also had diarrhea, but it's usually mild, grade 1 or 2. So the next question is, which of the following statements is true regarding radium-223? Number 1, PSA declines are common. Number 2, treatment is completed within 5 weeks. Number 3, overall survival was extended by 30% compared to placebo. Number 4, radium-223 is approved for men with mCRPC with visceral metastases. And number 5, alpha particles have much lower energy than beta particles. So the answer to this question is number 3, overall survival was extended by 30% compared to placebo. All of the other statements are true, and I just want to comment that PSA declines are not common with radium-223. So this is very important to make sure that your patients are aware that their PSAs may not decline while on radium-223. The other issue is that treatment, as I mentioned earlier, is monthly treatment for 6 months. The 5-week treatment is Sipuleucel-T, the immunotherapy. And as I mentioned before, no visceral metastases should really be considered for radium treatment. So in conclusion, we're really in a very interesting and exciting time in prostate cancer treatment, particularly for the management of metastatic CRPC. There have been multiple agents approved over the past several years that really have outpaced our ability to understand, in particular, how to sequence or combine these treatments. The next few years, you'll be seeing a lot of research on trying to understand the optimal sequence and integration of these different therapies. The other interesting area of research is about the cross-resistance to AR pathway inhibitors, since this is such an important driver of prostate cancer. Although there are some treatments such as radium and chemotherapy that do not appear to be dependent on AR, we know that understanding the AR pathway better will actually improve our ability to keep these cancers under long-term control. So if you look at the graphic of the FDA approvals and the chronology, you can see that for many years we were in a relative desert of poor treatments that had no survival benefit, such as estramustine, strontium, and samarium. Mitoxantrone also, the first chemotherapy approved in 1996, had no survival benefit. But in the last few years, we have a whole host of new treatments and indications, all of which you've heard about today in terms of both treatments that prolong survival but also improve quality of life in patients with CRPC. And so the last slide really focuses on the treatment landscape, which has been significantly altered in prostate cancer. We know that some patients are cured with local therapy on the left. If they relapse, they receive primary androgen deprivation therapy, and many of them will go into remission, but they are often not cured in the setting of metastatic disease. When they do start to progress with the PSA that's again rising, they have a series of treatment options that are listed here in their general areas where they'd be used. Sipuleucel-T at the earliest point, but you can also consider subsequently Enzalutamide and Abiraterone, radium-223, and then usually chemotherapy with docetaxel and or cabazitaxel. Patients should continue on lifelong androgen deprivation therapy in the setting of CRPC, which is shown in the blue bar at the top, and considered for bone-targeted treatments such as zoledronic acid or denosumab as adjuncts to the life-prolonging therapies noted below it. In the end, we'll still be trying to figure out how to optimize this for individual patients, but I think it's absolutely an exciting time in the management of these patients. So with that, our program is concluded. I want to thank everyone for joining us and thank my colleagues for really, I hope, what was an illuminating presentation on the current management of metastatic CRPC. Thank you.